So, good afternoon, everybody. We are starting the session. Today, we are taking interactive question and answer session for our registered candidates. This is not a training course right now what we are conducting, but a question and answer session for registered candidates who are undergoing different server-based courses. So today we got a list of questions. I will display the questions also. We will be taking the questions from that list, and that list contains the questions which is posted by our registered candidates. Now you can see on the screen, first that Dr. Pratima is posting how to measure the biparietal diameter, how to measure the ACFL fetal heart rate. Question number one. Question number second is that how to adjust the frequency while doing the grayscale and color Doppler. Third is that how to measure an amniotic fluid in case there are loops in each and every cord. That is the question. Questions. These are the questions posted by Dr. Pratima. And one more question from Dr. Ramesh is that he's having a query that regarding M mode. These are the copy pasted questions. What I mean by copy pasted, as we got these questions, we pasted it over here. So the first question from Dr. Ramesh is that I have an inquiry regarding M mode. Is it have gate? In my Samsung R7 R5 machine does not have gate for M mode. Please enlighten on that issue. Next, the question from Dr. Ajoy is that how to diagnose a pyloric stenosis. Then Dr. Taranum Akhtar is posting what is the size of the normal fetal kidney and the urinary bladder. Next, Dr. Tripti is posting why the follicles looks like this. This means she has actually sent a clip, not actually a clip, a pic of the follicles while it looks like there is a follicle in the follicle. So how to measure in that case if we are having a multiple follicles looking like a follicle in a follicle. So next question from same doctor is that sometimes it looks like a rectangular follicle is over there, 26 into 13, for example, where the measure. Next question from Dr. Tripti, same doctor, is if we are getting cord in each and every, this is the repeated question, I think. So if the question here is that if we are having cords in each and every quadrant, what to do, how to measure the amniotic fluid by Dr. Tripti. Then Dr. Ramesh is posting regarding the M mode, which I have taken. Then luteoma and hyperactive luteinalis, how they are looking like on ultrasound by Dr. J. So these are the questions posted by our registered candidates. We will take one by one these questions. So I will be keeping on display these questions on this TV over there so that you will be able to see it all time. Just hold on. So first question, you can see on the board. I have displayed these questions over here. So the first question by Dr. Pratima is that how to measure HC, BPD, AC, and FL. We have discussed this thing in our course. Right now, repeating, we are not taking a course over here. So I will be giving a brief because the question is already posted over here. Now, first thing is that how to measure the HC and BPD. When I say BPD, I am having a head over here in Excel section. We will not discuss it over here because this is already taken. How to take the section, what should be the section, like the transthalamic section. At the level of the thalamus, the the axial scan. Now in axial scan, I will be taking this head. It will look like, not a circle-like, but something like the oval shaped. Now to measure the BPD, now see, to measure the BPD, there is a bone. I have to include one-sided bone. Repeating, I can include one-sided bone and exclude the other side. It means that it can be from outer table to inner table, or from inner to outer. The purpose is to include one-sided bone only when I am taking the biparietal diameter BPD. So where to measure? At the level of, somewhere at the level of the transthalamic section. Now, how to get to this transthalamic section? That is already taken in your course. Right now, we are taking questions only. Now, for head circumference, HC. For HC, I have to trace this. I don't have to measure. I have to trace this all. What I mean by trace is that I have to take the caliper. I have to trace it. Whole, including the bones, I have to trace it. So here, no outer to inner table. Here, I have to include the bones also. So for BPD, I have to measure, and for SC, I have to trace. Trace what? Whole of the fetal head, not one-sided bone, like I said in BPD. Now, abdominal circumference, AC. When I say AC, where to measure? I have to measure it at the level of the stomach. Precisely, it has to be at the level of the portal vein. Portal vein look like a hockey. So if I say precise, it has to be at the level of the portal vein. Stomach can also do. Now, again, like I traced it in HC, I have to trace everything from the outer border, including the skin. So that is abdominal circumference. Next is the femur length. In femur length, I have to measure the shaft of the femur, shaft of the femur, excluding an epiphysis over here. So distal femoral epiphysis has to be excluded. So I have to measure the shaft, which will look like a, hockey, not actually hockey-like. So it will go straight and it will bend on one side, a slight bending over there. So that is this femur length. Now in femur length, there is a catch. If, for example, this is the femur over here. Now see, try to understand. If this femur is 90 degrees with respect to the throwing angle, with respect to the beam, if this is 90 degrees with respect to the beam, I will see this much of length from here to here. But try to understand. If I am having an oblique incidence, now see like this. So the beam is hitting like this, and the beam is hitting like this and this. Will I see here short femur like? Yes. So the point is that the femur has to be 90 degrees. So femur has to be horizontal with respect to the throwing angle, has to be horizontal like this, then only the actual femur length will come. And if it is a slanting in a slanting way, then I can say that this part can be hazy or this part can be hazy. So the overall femur length calculated will be short. So when you are taking the femur length, make sure that it is hitting by 90 degrees from one end to another. And it means that the femur has to be in a horizontal position. Now, next is the fetal heart rate. In fetal heart rate, what I have to see, I have to, some machines, I know why the confusion is, why this question has been posed. Some machines are asking for alternate waves. And some machines In some machines, I can take subsequent waves. Now, for example, you got this fetal heart over there. So in most of the machines, you have to take from one and don't stop over here, go to the another. And once you set over here, the the fetal heart rate will pop up over there. So it has to be on alternate, skipping the subsequent one. So it has to be on alternate waveforms. I mean the fetal heart rate. But in some machines, I don't know now which machine you are using. In some machines, you have to trace it from the first and freezing on the second. So in about a 99% of machines, they are asking for alternate waves. Next question from Dr. Pratima is that how to adjust the frequency. Now see, how to adjust the frequency while doing grayscale and color Doppler means at what frequency I have to do grayscale. Dr. Pratima, you are posting a question that how much should be the frequency? How can I say how much should be the frequency? It has to be decided by you depending on the habitus of the patient. If patient is obese, then you have to decrease the frequency. If patient is thin, then you can increase the frequency. Now, why that knob is, the point here is that without changing, give me the probe. Without changing the probe, you can, change the frequency. Now, this probe, the transabdominal probe or any TVS probe, is having a set bandwidth frequency. It means that you can change the frequency of a given probe without changing the probe from 2 to 5. So in some machines from 2.5 to 5.5. So there is the first knob, the frequency knob. When you will clockwise or anti-clockwise rotate it, it will start decreasing or increasing the frequency. So the machine will show you what frequency you are using in a particular probe. Then depending on your requirement, whether to increase or decrease, the knob for the frequency, you have to change it, not change it. You have to, rotate it clockwise or anti-clockwise, and the machine will show you that you are using right now a 3.5, and while you are rotating it, it will increase, and then you will say, yes, this much is sufficient, because here the patient is not so much obese or is not thin. You have to adjust it like this. So the point here is there, in each and every probe, there is a bandwidth frequency which you can change without changing the probe, depending on the patient. And in obese patients, you have to decrease the frequency, because in obese, you need penetration, and in thin patients, you can increase the frequency. By increasing the frequency, the resolution will increase, but at an expense of penetration. That is already discussed in your physics and machine settings. I will request you to go back to that class. That class is about 20 minutes of this frequency versus frame rate. So next question from same Dr. Pratima is that how to measure an amniotic fluid in case, how to measure an amniotic liquor, an amniotic. These are copy-paste questions. That is why I'm trying to make out the question. So how to measure the amniotic fluid? It is in the amniotic fluid index class itself. So you have to take the 4 quadrants and keeping your probe perpendicular with respect to the body. You have to keep the probe perpendicular with respect to body, so that you are not hitting another pocket from here, thinking that I am scanning from here. So this is the class itself. This is the course itself, which is about a 1 hour class, how to measure in amniotic fluid index course. So now the question is that if there are loops, in the cord, I told you in class that if you are having more of cord, then you cannot take that pocket. More of cord means that visual impression. You cannot calculate the volume of the cord in a given pocket. Visually, if there is more of cord and less of fluid, you cannot take that. So skip that. And here you have to put a color box, because sometimes it looks like that this is the fluid, because in cord there is the fluid itself, there is the blood, and on grayscale it is not always very clear whether I am dealing with a cord filled with loop filled with cord or loop having the fluid. So put a color to make sure that there is not more of the cord. Dr. Ramesh, I have query regarding, I am reading the question. I have query regarding M mode. Is it have gate? Now see the question here. I am having query regarding M mode. Is it having gate? In M mode, we don't have any gate. In M mode, we don't have any gate. In M mode, a line will be there. A line will appear with a small line onto that line. Once you switch from B mode to M mode, what will happen? A line will appear, and in that line I will be having a small additional line. You have to take that small additional line and you have to put that on the fetal heart. Now you will see that a line will appear with a small additional line. You have to put this line onto the fetal heart. In over here, I will not have gate. Gate will look like this. Not this. You will see this line, small line, and when you are doing M mode tracing for fetal heart, and this is gate. In M mode, I will not have any gate, but I will have a line over here. So you have to put that line in that particular on the fetal heart. Next question from Dr. Ajoy, what is the pyloric stenosis? I will take that in detail. Next question from Dr. Taranum Akhtar is that what is the size of the normal fetal kidney and urinary bladder? Now the normal size of the there is a chart. There is a chart that for this much of gestational sac, age, I should have this much of kidney size, but roughly the kidney size, the size of the kidney from top to bottom, the size of the kidney will correspond with the gestational age in weeks. Roughly, this is not a hard and fast rule. It means that if you are scanning a 32 weeks fetus, you will expect a 32 millimeters of kidney size. Now, if kidney is enlarged in size, it will be maybe a 50, maybe a 60. So roughly it is equal to the gestational age in millimeters. And if you want a precise measurement, then you can download a chart. But I feel that this thing will also do that measuring the kidney with respect to the gestational age. Next question from Dr. Tripti is that sometimes there are looking follicles in a follicle, how to measure in such cases. And the next question is that sometimes, next question from the same Dr. Tripti is that sometimes I see a rectangular type follicle, what to do in that case. Now, in ovaries, Not always there will be only one follicle. I mean the dominant follicle. Sometimes there can be multiple follicles. There can be 5, 10, 11 follicles in the ovary. Now, if, try to understand, there's a physics behind this. If one follicle is this much big, if one follicle is this much big, and another follicle is behind this follicle, and that is small. For example, this is the follicle, and another follicle, a small follicle, is behind this. And you are scanning. Now see, you are scanning. Your beam is hitting, cutting this, and at the same time, there is one more follicle behind it, and that is also getting cutted. What you will see, like that this follicle, now see, this big follicle is containing one more small follicle. Actually, the small follicle is not in a big follicle on ultrasound, because the beam, because the ultrasound is cutting in such a way, in this case, that the bigger follicle and the behind small follicle are cutting in the same plane. So it will look like there's a follicle, this much follicle, and behind this big follicle, there's a small follicle which is also getting cutted in the same plane. So you will see another follicle anywhere. It can be in center, it can be at periphery, looking like a follicle in a follicle. You change your scan plane, you scan from a different angle, you will see that previously this follicle, which looks like containing the follicle, this follicle will start disappearing. So there is no follicle in a follicle. It is because of the beam which is cutting in such a way that the behind follicle is also been cutting in the same plane. Now, not always, the second part of the question, not always the follicle is round. Sometimes it is like an oval structure, not actually a rectangular, what she is writing over here. Sometimes it is like an oval. So then you have to take two measurements. One, 33, for example, and another 22. So you have to take two measurements. So this was about the question posted by Dr. Tripti. Query, Samsung, yeah, done. Now the question from Dr. J is luteoma, and Dr. Ajoy, how to diagnose a pyloric stenosis. So we will take this pyloric stenosis now. Let me share the screen. Is it shared? None? Now, see, when I say pyloric stenosis, now see, ultrasound is a helpful tool over here for diagnosing this pyloric stenosis. The technique is that first you have to locate the gallbladder. You have to locate, try to understand, you have to locate the gallbladder first. Once you located the gallbladder, then turn the probe obliquely to scan what? So that your probe is getting hitted more sagittally and taking an attempt to identify the pylorus, and that pylorus will be in longitudinal section. So locate your gallbladder first, and then take an attempt to hit onto the pylorus sagittally, and when you are hitting that pylorus will be hitting in a longitudinal section. Now the hypertrophied muscle, you don't have to measure. Now see, this is the pitfall over here, not actually a pitfall, the mistake, that we are measuring both walls, anterior as well as the posterior of the pylorus. No, you have to measure the muscle only, and muscle will be hypoechoic. That is what it is written. The hypertrophied muscle is hypoechoic and the central mucosa is hypoechoic. So you have to measure the hypoechoic muscle only. Now, pylorus thickness, how much the pylorus thickness, the muscle, the single muscle wall has to be more than 3 millimeters, So normally it is less than 3 millimeters. And here is the length also. The length of the pylorus should not be more than 15 millimeters. So 3 millimeters, the muscle thickness, and not more than 15 millimeters, the length of the pylorus. Now, the patient should be in the right decubitus position. The purpose here is that when the patient is turning in the right decubitus position, if any gas over there in the stomach will move up towards the fundal area, fundus of the stomach. So thereby you will be seeing a comparatively clear picture than left decubitus position. So try a right decubitus position also. So let me show you a picture also. Yeah. So this is the pylorus over here. This is the pylorus. This is the stomach over here. This is the pylorus. So this is looking like the cervix. Now see, this is looking like a cervix over here. And if it is looking like a cervix, it is possible that it is hypertrophied. So you have to measure the muscle only, not whole of the anterior wall over here. So you have to measure the muscle which is hypoechoic, and the muscle should not be more than 3 millimeters. And the overall length should not be more than 15 millimeters. So this way you can measure the length of the pylorus, and this length of the pylorus should not be more than 15 millimeters. Now, next question from one more doctor is that what is hyperreactio luteinalis? Now, the hyperreactio luteinalis is a rare condition. This is not very often. So this is a rare condition in which I am having an elevated level of beta HCG, like in gestational trophoblastic disease or in multiple pregnancies. The appearance of the ovary will be that bilaterally I will be having an enlarged ovary with multiple, mind my words, you can note it down, with multiple thin-walled structures in it. So there will be multiple thin-walled areas in this, and the cysts will be clear. And sometimes there can be a significant solid component representing the ovarian tissue, but usually they are clear. They don't require any treatment and resolve on evacuation of the molar pregnancy or in some normal pregnancies or post deliveries also. So there will be a big ovary over there with multiple septations, clear septations in it. Now the luteoma. What is a luteoma? Luteomas again is a rare non-neoplastic condition in which luteinized stroma cells in the ovary markedly increase in size. And here I will be having an association with hirsutism also. Now ultrasound. What ultrasound will show you? In ultrasound, I will be seeing not a cyst, clear cyst now. I will be seeing more of the solid component in the, most probably I am having a picture also. So I will be having, yeah, got it. So I will be having the cyst with a solid mass-like structure in it. So it will look like a, a dermoid, but not a clear cyst. And that is a luteoma. So these were some questions posted by some of our registered candidates. I hope that I have answered the posted questions. And in case you are having any more question, you can post in the chat box. Anna, have a look on the chat box if I am having any question. So I am requesting you to complete the topic first, then pose the question. Because if you will post a question from a topic which you have not even touched, there will be multiple questions. But after completion, there will be less of questions. I am not, scared of posing questions, but the things should be first clear. Then you can post any question. So post a question from the topic which you have completed, or at least you have started the topic. So waiting for your questions in the chat box, if any. Okay. No more questions. So I think that for now we are done with questions. We have completed the questions. See you very soon. We will post in your batch group when we will take the next session. Regarding that, we will send you the information, and you have to send your questions so that I can make a list and can discuss in detail the question. That is why it is preferred to post the questions before the interactive sessions. And even if you are having right now questions, you can come forward via the chat box, or you can directly post me question by unmuting your computer or raising the hand, not this hand. There is a more option. In more option, there is a raise hand. If you still have any question, you can post that directly to me. Now, Dr. Praveen is posting a question. Sir, kindly elaborate how to see the fetal lie in the fetal position. You have not yet completed the fetal ultrasound, because this fetal lie, fetal position is detailedly covered in one of the class in the fetal ultrasound. So I will recommend you, I will suggest you to first, that is what I told you some 2 minutes before. You can post any question from the topic which you have completed, or even you have started. You have not even started this topic. It is there on the server. Right now, we are taking question and answer sessions only. We will not take the whole of the ultrasound course in this session. So this is for question and answer session. The fetal lie position is there in the fetal ultrasound. You are suggested to go and first complete that topic. And even after completion, if you have any question, you can come forward. So this is a class in the detailed fetal ultrasound. Okay, so this is all for now. See you very soon. We will announce in next week our next interactive session. Thank you very much. God bless all of you.